hello to all my dear students. So this is Dr. Ruchi Rai and we are going to start with our ophthalmology lectures starting with introduction. So what am I going to discuss in introduction with you all? I'm going to mainly talk about the general, it's like saying hello to the eye, right? And detailed anatomy and physiology will be discussed in individual chapters. This way it becomes more enjoyable to study. Okay, so before I per se start with my lectures, let me tell you something here. Please don't forget to make every single diagram that I'm making in the class. And whatever we are writing, let's write it together. Because whatever benefit that you're going to get from these lectures will be directly proportional to how nicely you have made your notes. Is it okay with you all? So please be very clear with that. Don't be lazy not to write, because you all know about picture memory. So if you have big diagrams in front of you, you can actually quickly revise your things prior to your exams. Okay? And secondly, very important, during the lecture, I keep telling this is Q, this is double Q. So you have to note it down. Double Q means it's a repeated question of your exam, and Q means it's your exam question. I think I'm repeating all this. I've already told you this again and again, especially for those who may have listened to me earlier as well, right? Okay, so let's start. So we will go from zero, from the basic to understand eye. So all of you, what is this white part known as? Make the diagram along with me. We start with the basics. So we make this diagram. The white part, this part is we all know sclera, isn't it? Okay. And behind this is your iris, which is giving the color to the eye. And above the iris, that is continuing from the sclera, this is your cornea, isn't it? This is your cornea. The opening in the iris, this one is your pupil. The opening in the iris, this is your pupil. Okay, so this becomes a little basic that we have to know. White wala is sclera and black wala jo aage, that you're looking at, is your cornea. Okay, what is the junction known as? The junction between sclera and cornea is what is called limbus. I hope we are drawing together. So that is called limbus. Okay, what is above the sclera? Can we think of it? So the commonest mistake which the students do, and what the answer I get is, ma'am, above the sclera is conjunctiva. No. Above the sclera, there's another tissue, episclera. Okay, it's a continuation, you can say the outermost layer of the sclera. Then above that is Tennant's capsule, and then comes the conjunctiva. Okay, so it's sclera, then comes your episclera, Tennant's capsule, write down please, Tennant's capsule, and then comes the conjunctiva, which is the superiormost part. So conjunctiva is like a thin mucous membrane covering the ocular surface, but of course you all know it doesn't cover the cornea. Okay? So, or if you want to write like this, maybe we should write something like this. That's sclera. Above that, we can, for your convenience, we can write like this: sclera, then episclera, then comes your Tennant's capsule, so that you don't learn reverse, right? And then the conjunctiva. Now, what are the parts of the conjunctiva, guys? So, we know it is bulbar conjunctiva here. Then the fold is called fornix. And make this is your upper lid. This becomes your lower lid. Okay? Simple representation. Simple diagrams. So, this is your palpebral. This part, which is the part covering the lids, here is palpebral conjunctiva. Palpebral conjunctiva. Okay? So it is bulbar, fornix, and palpebral conjunctiva. Right. So once you know this, we are clear with this? Okay, we come to the next diagram. This one is your master diagram where we are going to really learn a lot of things about eye. So make it nicely and don't save paper at this point at least. Make a big diagram, please. So let us draw this together. So if we are drawing this structure of the eye, so once you start drawing with me, you're going to become pro in drawing it. All of you draw with me. Iris. And this is the outermost layer is your sclera. Simple way of drawing the eye diagram for you. Okay. Only simple concept should be clear. Then we have, after iris, what is the next part in the uveal tissue? Is ciliary body. This is the rough part. This is the plain part. This is the rough part. This is the plain part. So this is your ciliary body. What is that rough part known as? I hope you all know. Okay, let us draw first. Then this is your ciliary body ke baad choroid. And the innermost will be your retina. The dotted line that I am drawing for you all. This is your choroid. And this dotted line here is your retina. Okay, so these are the three layers of the eyeball. Clear it? What is behind the iris? All of you note down here. Behind the iris is your lens, isn't it? So we'll draw a lens here and it is supported by suspensory ligaments. Correct? Now, so the three primary layers of the eyeball, what you have drawn here, this is your sclera, then the vascular layer with iris, ciliary body and choroid, and this one is your retina. Done? Now, then we will learn that the whole eyeball is divided into two segments. One is your anterior segment and second is your posterior segment. So, including the lens and anterior to the lens is your anterior segment and behind is your posterior segment. Anterior segment is further divided as anterior chamber and posterior chamber. It is further divided as anterior chamber, posterior chamber. What is it filled by? We all know aqueous humor. And behind the lens, this is your vitreous cavity filled with vitreous humor. So the whole posterior segment is filled with what? Vitreous humor. We all know this. And we should know that vitreous is a gel. Okay. Once we know this much, so don't make a mistake between segment and chamber, please. So that's why I'm starting from the basics. Okay. So once we know this, another thing, from where is aqueous formed? Let's see. Aqueous is formed from these ciliary processes. So this rough part of the ciliary body is called what? Pars plicatum, and the plain part is called what? Pars plana. Right? So rough part is pars plicatum and plain is pars plana. Now this rough part of the ciliary process is, it's rough due to the ciliary process, and this is the place from where the aqueous is formed. Okay? Question. I want a cue here, please, all of you. How many number of ciliary processes are there? So we will learn it is 70 to 75. These are what? Write down number of ciliary processes I'm talking about. Okay? So many of you ask me, ma'am, one eye or two? Of course, one eye. We are talking about one eye, right? Many of you ask this, ma'am, is it one eye or both eyes? So of course, it has to be one eye, right? Okay. So, coming further, the aqueous that is formed from the ciliary process. What happens to that aqueous? It goes into the posterior chamber. I hope you all are drawing with me. Then through the pupil, it comes to the anterior chamber. From the anterior chamber, it goes to the space, which is peripheral space between iris and cornea. And this peripheral space between iris and cornea is what is called angle of anterior chamber. So, this angle of anterior chamber, do you understand what I am saying? What is the angle of anterior chamber? So, understand this way. This is the iris, above is cornea. So, what is this peripheral space? It is all length. So, all this 360 degree, this peripheral space is the angle. Can we draw it in this diagram to understand? Very simple. Angle, this is the iris, above this is cornea. So, this will be the peripheral space which is called angle of anterior chamber. So, do you realize that angle which is inside is corresponding to limbus outside? So, just to make your concepts clear, we can make a box here and I want you to write in the box. Write down, angle is all 360 degrees which is corresponding to limbus. Write it down, I am not writing but you have to write. So, angle is like all 360 degrees which is corresponding to limbus from outside. So, if I have to reach the angle, I have to dissect from limbus. Clear it? We go back to this diagram. So, coming here, what happens? Angle has channels. We'll talk in a lot of detail in your glaucoma chapter as well. So, how these are called trabecular meshworks. TM, I'm writing, means trabecular meshwork, and from the trabecular meshwork, this is going to Schelm's canal, SC is Schelm's canal, and then it is reabsorbed in the And actually there's vein of Asher and collector channels, and finally it is going into what? Episcleral venous system. So to make things easy, we have just starting, so we'll learn like this. How the aqueous from the trabeculum ischius, Schenck's canal, and it goes into the episcleral venous system. Done? So this is how the aqueous is formed and drained. Okay? Done? Now we talk about another interesting thing. What is the mechanism of vision? So let's see. Parallel light rays are falling on your cornea. Correct? So when parallel light rays are falling on your cornea, all of you, do you realize there will be bending of the light rays? What do you call that? Refraction. So bending of the light rays or refraction will occur at the cornea, major part, but it will also be contributed by both aqueous and vitreous humor. Remember that. And of course, both the major refracting surfaces are cornea and the lens. Okay, so these parallel light rays which are falling on the cornea, let's just understand, are bent at the cornea, then bent at the lens. The first point where it is first focused, okay, is situated just behind the lens. And this is what is called the nodal point of the eye. Got it? Keep listening. We will write it together. So, what did I say till now? Bending in the cornea, bending of the lens, it is focused first. Add a point behind the lens, this is the nodal point. Here the light rays will cross. When it is focused, now the light rays are crossed. That means here what will happen? That this image becomes inverted. So at the nodal point, when the light rays are crossing, image becomes inverted. The same inverted image falls on the retina here like this, okay? And it is our brain which will make it straight. So this is the whole basic story of your eye. Got it, all of you? So please remember this. How the light rays falling on the cornea, on the lens, are focused at the point just behind the lens. This is the nodal point. Light rays will cross, image gets inverted here, and finally the same inverted image falls on the retina. It is our brain which will make it straight. Okay, so once we know this, we can write it for ourselves, please. Make a box. Again, when I ask you to make a box, please do make a box. It will help you to see, okay, this was important in my notes. So what is a nodal point? Write down. It is the optical center of the eye. Okay, or you can say optical, write down with me, center of eye, or first focal point situated just behind the lens. First focal point situated just behind the lens. Right, all of you? Okay. If we know this much, let's now time to first have a look at a few nice slides of your structure of the eye, and then we will move further. Okay, so look at this slide. So this reminds me to tell you that if you are asked what is the shape of the eye, we will learn it is oblate spheroid. Okay, right. We come to the next slide. Capacity, it weighs 6 to, somewhere it is written 6.5, so 6 to 7 ml. But nobody will ask you this, just remember the shape is oblate spheroid. Okay, I think this is better slide here. Okay, so let's see this slide. I think we have already drawn all this for ourselves, that this is the cornea, iris, we have drawn it, right? And what else is showing? Of course, suspensory ligaments. These are the suspensory ligaments. This is your lens. This one is your lens. Of course, anterior chamber filled with aqueous humor. This space becomes posterior chamber. This is all is anterior segment, and this is your vitreous humor posterior segment. The 3 layers are shown here: sclera, choroid, and the innermost is retina. Of course, when we say choroid, we mean choroid posteriorly, which extends anteriorly as ciliary body and iris. Let's see the next slide, we'll understand. But what is optic nerve? Everybody knows. When all the nerve fibers from the whole retina aggregate and form at the disc, this is forming the optic nerve. So this 3D I chose so that it's even more easy to understand for you all, that how this is it's the same repetition. Just have a look. The cornea, iris, the opening is called pupil, right here. This is your pupil. Aqueous humor, lens here. Ciliary muscles. We know this. So, and yes, I want to point out here, this is not blind. Never please never label it as blind spot. We will discuss more in your glaucoma. Blind spot is a scotoma. It is in the visual field. This is your optic disc, we will say, not blind spot. It is optic disc, and corresponding to optic disc, the scotoma is called blind spot. Now you will ask, ma'am, what is scotoma? So any non-seeing area surrounded by a seeing area. So if you're not able to see something in your field, this is a scotoma. Again, let's wait. We will talk in detail further in the chapters. Let's see what we have the next for us. Yeah, again, I think it's very simple. So this is again, I just chose all these 3Ds so that you are very, very clear about the structure of the eye. No use repeating, everything is there, you know. Of course, one new labeling here is macula and fovea, which is nothing but central retina. We'll come to that. Yeah, it is. These are showing you this. This is the suspensory ligament, right? And the ciliary processes and how it is attached here. And what I wanted to show you here is to have a concept that how this is, if this is the angle, if this is the iris, right? So, and this is your cornea, correct? So, this becomes your angle structure, right? So, in this angle structure, what do you see here? We see this is canal of Schelm's. Just have an idea about trabecular meshwork and canal of Schelm's. These are the structures in your angle. Okay. So, another important thing why I chose this. So, when you see retina is the innermost layer, you have to realize it is not totally till anterior part. Retina will stop at the ciliary body, pars plana. And the most peripheral part of the retina, we will label it here as ora serrata. Okay. The most peripheral part becomes ora serrata. This is again giving you an idea about the angle structures which I taught you, that if this is the iris, this is the cornea, this becomes your angle, so this becomes your anterior chamber, right? All of you? So this becomes your anterior chamber angle. So anterior chamber angle has this trabeculum. This is showing the trabeculum, this is the Schelm's canal, and how it will be reabsorbed in the episcleral venous system. Very clear idea what is posterior chamber, what is anterior chamber. I think this is helpful. I'll just rub all these markings so that you can have a nice look at it. Okay? So this was about your structure in the and the angle of the anterior chamber. Okay. So this is also telling you about the outflow, how the aqueous which is formed here from the posterior chamber, it is going to the through the pupil anterior chamber. Okay, when it goes through the trabecular pathway, we call it conventional pathway or trabecular pathway. Sometimes it just crosses directly the uvea and sclera when you call it uveoscleral pathway. Again, we'll wait for the details for the glaucoma chapter. Right? So this is how you draw the eye. I think I've taught you a very simple way how to draw the eye. The color coding was quite impressive, so I thought I'll show you this. Right. So we know that the red color is your mainly the vascular layer. I was showing you the iris, ciliary body and choroid. The yellow one is your retina and how the nerve fibers form the optic nerve. Right. And this outer blue one is your sclera, outermost coat sclera, and how the muscles are attached on the sclera. Right. And if you see here, the white part, this one is your cornea. So now everybody is clear about the structure and anatomy of the eye, isn't it? This one just taught you how there will be, if there is an object here, the light rays are bent at the cornea, bent at the lens, first at the nodal point, and from there then an inverted image is formed at the retina. Okay, we could come back to our diagram. What are the other things that we have to know? We just learnt about the nodal point, right? Now, very important after this, we should know, where is the bending more? Is it at the cornea or at the lens? We were talking about the bending of light rays. Please remember, the bending is more at the cornea. And this is a very important exam question, why? Can you think of why? Okay, so there are two main, so how is the question asked? Can we note down the question, please? All of you make a cue and write down. Most important factor to focus light rays on the retina. Most important factor to focus light rays on retina. So what did I say? The refraction is more at the cornea. So we have to understand why at the cornea. There are two main reasons. One, of course, there is difference of refractive index between air and aqueous humor is the water or aqueous humor, right? But above this, the most important factor that you have to understand is curvature of the cornea. So here the answer to your question was curvature of the cornea. फिर आपसे पूछा, they have also asked you and given you an option, anterior surface, curvature of posterior surface. Definitely anterior surface, है ना? So we will answer this like this. It is a curvature of cornea, anterior surface. Okay, we will make a Q here. And of course, the second most important factor is difference of refractive index between air and water, air and aqueous humor. This is the second factor. This is the second most important, why the cornea has more refractive power than the lens. Done? Okay. Now, this fact is asked by a very interesting question. Suppose you are swimming underwater. I think majority of you know how to swim, and if you don't, you should learn that. Right? It's life-saving. Anyway, if you have not swimmed ever, then you can just relate it to if you are washing your your face and splashing water into your eyes. Do you realize you don't see clearly? Or if you are swimming underwater, you don't see clearly unless you wear the goggles. So why? This is the reason why. Because when you are underwater, what is happening now? When we are underwater, now the media becomes water and water. And when the media becomes water and water, what will happen? Less bending, because no difference of refractive index. And when there is less bending, naturally the less refraction means the vision is not clear. So the answer, this was your exam question again. Can we put a Q here and write that if you are underwater, why the vision is less? This is the question. Your answer is due to loss of refraction. The answer was loss of refraction. Why? Because now the media is water and water. Both are liquid here. Interesting? Okay. So, let's go back to our master diagram. I call it a master diagram. We discussed so many things here. अब बताओ मुझे एक और चीज. Do you realize after I have told you the whole story about the eye that the main role of cornea and lens is to focus the light rays? Correct? And what is the main role of retina is vision? This much we know. Do you realize something? Because the main role of cornea and lens is refraction and focusing, it is very important that it should be absolutely transparent. And because both cornea and lens should be absolutely transparent, this is the reason both cornea and lens are avascular. Can we note it down? So write down, both cornea and lens are avascular. And from where do they get their nutrition? We know it, aqueous humor. Anything which is circulating can only give nutrition. So answer should be aqueous humor. Done? Okay, so this was another important point. Now, let's again come back to this diagram. Do you also realize that everything is at its place? Everything is at its place. Nothing is moving inside the eye. Whole structure of the eye is in front of you here in this diagram. And the only tissue that is circulating is aqueous humor. So, common sense that when will be the pressure more in the eye? The pressure is going to be more when amount of aqueous is more. And when is the amount of aqueous more? Either it is formed more or it is drained less. So, common sense. Any imbalance, majority of the time it is less drainage. When there is less drainage, what happens? More aqueous, and sometimes of course more formation is also a factor. More aqueous in the eyeball raises the intraocular pressure. Right guys? Okay, let's make it here and mention it. When increased intraocular pressure, what is happening next? This is going to press on the optic nerve and optic disc. Let us draw that. So, if this is the optic disc, right? So, let me rub a few things. So, if this is the optic disc, any pressure on the optic nerve and optic disc will lead to damage of the optic nerve, and this damage of optic nerve is what is we call glaucoma. Please be very, very clear. Glaucoma is not mere increase of pressures. There are cases where the patient is glaucomatous though the pressures are normal. We call it normal tension glaucoma. Again, we will discuss the details. Here what you have to understand, more pressure, damage of the optic nerve leading to glaucoma. Okay. So what is happening? This is the disc. All the nerve fibers have aggregated into the disc. Crossing the retina, the choroid and the sclera, the nerve fibers that are aggregating will come out as optic nerve. So it is crossing this choroid, the sclera. And then entering where? Where is this eye located? Inside the orbital cavity. So that bony cavity is called the orbit. So this is the part. Now listen here. Part of sclera at this optic disc where it is exiting out is not like this, but it is actually sieve-like with lot of pores inside it. Okay, sieve-like, channi ki tarah. Through these openings, the nerve fibers are exiting out, and this part of sclera is called lamina cribosa. Okay, so this part of the sclera is what is called lamina cribosa. Done, all of you? So that was little bit basics that we had to be very clear on this diagram. Okay, so what next? We'll next talk about, let's make another diagram. So when you talk about, what did I say? The nerve is reaching where? So make the orbital cavity, all of you. So this is your orbital cavity. Make simple diagrams for your understanding. This one is our eyeball. This is your optic nerve. It is coming out from the disc and forming into the orbital cavity. I'll show you the slide also. Few questions out here, all of you. Make a cue. What is the capacity of the orbit? We will answer capacity is 30 cc. What is the shape of orbit? It is quadrilateral or pyramidal in shape. Quadrilateral or pyramidal in shape. Okay? And what is the length of optic nerve? Length of optic nerve, we answer it is 5 to 5.5 centimeters. Okay? So we learn the length of optic nerve. Take it? Okay. Then once you are doing all this, so can you also tell me what is the axial length of the eye? So what do you mean by axial length? Axial length means what is the antero-posterior diameter. So of course it varies. But if you have to choose any one value, we generally say 24 millimeters is the axial length. Okay? Think yourself, how are you going to measure the axial length? Antero-posterior seems to be a challenge. So how are you going to measure the axial length? Ultrasound. Let us learn. Ultrasound in the eye can be either A scan or B scan. And how we will learn A for A? A scan is used for axial length measurements. What is B scan used for? So if suppose the patient has cataract or there is a corneal opacity, how will you see the retina? How will you see behind? We can do a B scan. So write down, B scan is used to see the posterior segment of the eye. B scan is used to see the posterior segment of the eye. Okay? Okay. So if we have this idea, another interesting thing I'm telling you. What is the depth of anterior chamber? So what is the depth of anterior chamber? You remember anterior chamber, posterior chamber. So we are talking about anterior chamber, which means we are talking about the space between iris and cornea. Right? Of course, it varies. The periphery it is different, but average, what is the depth? We will say it is around 2 point. Just, I'm giving you a tip. You have to put a dot between 24. You just learned with me that axial length is 24 mm. Now put a dot there. It is 2.4 to 2.5 millimeters. What are we learning here? So, depth of anterior chamber. Okay? Okay, keep listening. This 2.5 value comes at many other places in ophthalmology and it is asked in the exam. So now what are the other 2.5s in ophthalmology? So this is the way I generally teach in introduction to help you learn. So what are the other 2.5s in ophthalmology? So two very important points regarding this 2.5, both that you should know are cues. Make a cue there. One is definition of anisometropia. Anisometropia. What is anisometropia? We will say difference between the power of two eyes of more than 2.5 diopters. We are talking about refractive power between two eyes of more than 2.5 diopters. Another 2.5, again very important exam question. Infant is hypermetropic by. So a small child, definitely common sense, small eye. Huh? If the eye is small, what is the refractive error, all of you? Hypermetropia. How much hypermetropia? This is your exam question. So they have asked you in two ways. They have also asked you like, what is the refractive status of a child, newborn or of an infant? They have given you the option myopia, hypermetropia with astigmatism. Now here you get confused. Please don't answer that. Our answer is simply hypermetropia. So infant is hypermetropic by, you will answer 2.5 to 3 diopters. It is 2.5 to 3 diopters. Right? Remember? Great. Okay. Another important thing, a basic we have to know is about retina. We'll make these diagrams and then I'll show you the slides. So if I'm trying to explain you the retina, the basic that I want you to know. When you are looking straight ahead like this, you're looking at the posterior part of the retina. This is the central part. What you have to understand, it's an oblate spheroid. It is going like this. So you just imagine my eye. You're looking straight, it is the central part. You want to look at the periphery of the retina, you have to come anteriorly towards the pars plana. This is what should be very, very clear to you. Central is posterior and peripheral becomes anterior. Okay? So, but when we are drawing, let's draw it in a simple way. If we talk about the retina, retina can be central retina, mid-periphery, periphery. Just draw like this, a simple diagram to understand. I'm not drawing all over, just this much to understand. So if this is the central retina, this becomes the mid-peripheral retina and this is your peripheral retina. So central retina, two major structures we all should know, optic disc, from there the nerve is exiting, and of course the very important part which is responsible for our central vision is the macula. Isn't it? Okay. Macula, now again learn with me, 5 to 5.5 millimeters is the diameter. We just learned about 5 to 5.5. Oh, just show. Wait a minute. Do this correction. Do this correction here. It is 3.5 to 5.5 centimeters. I'm sorry for this. Just make this correction. It is 3.5 to 5.5 centimeters, the length of optic nerve. And also, there was a question where all these options were given, where it was ranging from 3.5, 4, 4.5. What to choose now? All are correct because it's a range, it's a physiological range. In that case, we answer 5 centimeters. Okay, so if one value you have to know the length of optic nerve, it is 5 centimeters. So please make this correction, sorry for this. We come back to, we were talking about retina. Okay, so 5 to 5.5 is your diameter of the whole macular area, which is the central retina. Inside this area is most sensitive part of the retina. Exam question, most sensitive part of the retina. This is what is called fovea centralis. Okay, all of you make a Q and write down most sensitive part of the retina. Inside this fovea centralis is another area which is called foveola. Okay, right? And a very center has a small depression. This is what is called umbo. So now you very quickly, we'll talk about it in detail in retina chapter as well, but you have to know that, you have to have the idea. Macula 5.5, which is also called macula lutea because it is yellowish, or area centralis or macula. Just remember that. After that, within this is your foveal area, fovea centralis. Then comes foveola. Foveola, if you want to remember one more point here, it has only cones. We'll talk about it more in detail. Let's write just foveola. And a very central depression is umbo. So this is the structure, and everybody knows about temporal nasal, right? So macula is temporal and to the disc. When you say temporal, it is away from the nose. Nasal means towards the nose. So if this is the retina I have drawn, this becomes your nasal part and this becomes the temporal part of the retina. Isn't it? Okay. If we are saying that disc is nasal, correct? And macula is temporal, isn't it? So whenever we have to answer this, that which eye it belongs to. Suppose the retina which I am drawing here in front of you, or is of which eye? So think yourself, your patient is in front of you, right? So it will be reverse. You are examining the patient like this, the patient is standing in front of you. So do you realize which eye can this be? So this is his, and when you are drawing like this becomes your left eye. Okay, because the patient is in front of you, the disc has to be nasal, the macula has to be temporal. So it becomes your left eye. So please remember, this is the way we will answer. Right? Now, most peripheral part of the retina is serrated. I showed you it in the slide also. We will draw here. This is called ora serrata. The most peripheral part which is serrated is ora serrata. Now, one question was most sensitive part, fovea centralis. They can ask you which is the thinnest part of the retina. Now this, pay attention. Till last year, we were answering this as ora serrata. Okay, but the latest edition of the Kansky is saying it is the fovea which is the thinnest part. So we can now please change it to fovea only. So again, thinnest part, note down with another cue. Let's answer fovea. Okay, till last year, as I told you, we were answering ora serrata. Then we talk about another question. The third cue on this diagram is distance of the disc from the fovea. So distance of disc from the fovea, this will be how much? Okay, so what is the diameter of macula? I told you. What is the diameter of disc? It is 1.5 mm. Okay, so diameter of disc is 1.5 millimeters. So what is the distance between two disc diameter? This is the way they ask you in disc diameter. So one disc diameter is 1.5. So here what we are saying is 3 millimeter. This is what we mean by two disc diameter. Okay, so on this diagram, what did you learn? That very quick review, retina can be central, mid-peripheral, peripheral. Peripheral most part, ora serrata, right? What else we learned? Central part has optic disc 1.5 millimeter and macula 5 to 5.5. Inside the macula, most sensitive part, fovea centralis, then comes your foveola and a small depression umbo, right? Distance between the temporal margin of disc to the fovea, not foveola. Okay, correct this. Don't make this. So this will be, we are saying, to the fovea. Just 1 minute, by this is your fovea centralis, and we can use any color. If this was your macula, I've just drawn again. So this is your fovea. So from the temporal margin to the fovea is your two disc diameter. Okay, so these are cues, that's why I have to mention it to you all. Okay. If I ask you what is macula, now you can answer me. It is the central part. That means you are looking at me through your macula. I am looking at you through my macula. Okay? So can we also understand this, that central retina is responsible for central vision and peripheral retina is responsible for peripheral vision, which is the visual field. So while you are listening to me, you are still aware what are the things around you on your table. This is your visual field or peripheral vision, isn't it? So just keep in mind, central retina, central vision, peripheral retina, peripheral vision. And what about optic disc? Please remember, no vision. So optic disc will not contribute to any vision, and this is the reason that whenever you are doing a field charting, you get one area where you can't see anything, and that is what is physiological scotoma. So optic disc is corresponding to this physiological scotoma, and this is what is called blind spot. This physiological scotoma is what is called blind spot. Okay? How do you check the central vision? Of course, central vision can be checked by visual acuity charting. You go for an eye test and you are told to read, okay, read what is this, DNHO, BUC, CT, PALO, right? So this is, you are testing your central vision. And how do we test our peripheral vision? I think everybody knows. Peripheral vision is by perimetry or visual field charting. Okay, so suppose I have to just a basic understanding you should have, that if I am testing the right eye and I have to see the function of the whole field. So do you realize what I'll do? I'm asking the patient, how do you do the perimetry? If I talk about kinetic, I'll talk in detail in glaucoma chapter about both kinetic and static. But here I'm giving you a rough idea. If I have to have an idea of your visual field, one eye closed, I ask you to only look at the central. So the patient is looking only at the central target. Now I bring another target from outside and I slowly move in front towards it. So, and the outermost point where patient can perceive the object will be the outermost limit of my field. Okay? The patient is looking straight here. And now what I'm doing? I'm moving this target towards it slowly, slowly. Suppose one point where patient says, I cannot see, I'll mark it. Then again I keep moving, keep moving, keep moving. Yes, yes, I can see. I again mark it. So the area where he was not able to see in the field, this is what we are saying is scotoma. And all of us, when we chart the field, will have this area corresponding to the optic disc. So it could be due to some optic nerve damage, but every one of us have one scotoma which is definite for sure is corresponding to optic disc, which is called blind spot. Now, if I have to check the whole field, do you realize the same process has to be on all the directions? Then only I can check the whole retina. So the different axes and planes in which I am checking the field, right? These are what are called isopters. Okay? So keep in mind this. If you want to write, otherwise it's okay. We'll write in the glaucoma chapter. Okay? Let's have a look at the few slides. So here in front of you, just a basic. This is the human retina, the central, this is the fovea, this is the optic nerve. So this becomes the temporal part, this becomes the nasal part. Now all of you, which eye is this? Which eye is this? Is it a right or a left? Can you all answer me this? Think yourself. So it is your right eye, isn't it? So this one will be depicted as right eye. Okay. So because you have to always think, it's not on your terms, but that the patient is in front of you. Then it will be easy for you to understand. Okay. Yeah, one more important thing, though I'm going to talk about it, when you just said about blind spot, right? We said that optic nerve corresponds to the blind spot, isn't it? So blind spot is which type of scotoma? So in any circumstance, you will always see that here I cannot see. So we call it absolute scotoma. And because this absolute scotoma is seen as some empty area, it is not seen a black patch in front of your eye, you call it is negative scotoma. So there are two terms here, absolute and relative. Okay, absolute and relative. Again, absolute means in any condition, even changing the size of the object, illumination, the patient is not able to see. It is absolute. And what do you mean by negative and positive? Keep in mind, negative means it's an empty space. Positive means there's a black patch in front of the eye. Imagine a black patch that you see in front of the eye. That becomes a positive scotoma. Okay? So this is blind spot. I'll talk more about it in the retina and in the glaucoma chapter or in neuro-ophthalmology as well. So just note down, at this point you will learn this. Blind spot kya hai? It's an absolute negative scotoma. Okay? Okay, let's see the next slide. Again, this one is, you have understood what is macula, what is fovea. Yeah, around the fovea, the area that can be, you can also call it as parafovea and perifovea. This is another way of describing the whole macular area. Okay, but the most important one was the one I taught you there. So we can keep that in mind. Yeah. So when you talk about what are you now looking at? So when we talk about retina, all of you, do you realize how do you observe the retina? How do you examine the retina? So why I pick up this in the introduction chapter? Because many of the students answer me, ma'am, we see the retina through retinoscope. No. Please understand, retinoscope is a misnomer. It is an instrument for doing a refraction of the eye. Okay? So retina kaise dekhte hain? Ophthalmoscope, or we call it fundoscope. Fundus is nothing but everything that you're seeing through the pupil inside, that is your vitreous, retina, choroid. So this is fundus. Okay, so synonymously we can call it as retina. This one is ophthalmoscope, is direct ophthalmoscope, and this one is indirect. So if you want, we can note it down here. This is your direct ophthalmoscope. So now you will not say retinoscope, right? So it is direct, and this one is your indirect ophthalmoscope. Correct. So these are the instruments to see the retina. And after that, what is this? This one, just recognize the head. Look at this head, right? and look at this one. So this is your retinoscope. We will see it many times, so you will know it very well. Don't worry. We start seeing it from the first chapter. Okay, so this is the retinoscope. And of course, this is showing you how the eyeball is placed in the orbital cavity. These are the muscles, right? Insertions. And of course, which one is this muscle? The pulley that you see through the trochlea. We are talking of superior oblique. We'll take in detail later. Okay, so this is the orbital cavity. We have learned the questions that it is 30 cc and the capacity is 30 cc and that the shape is quadrilateral or pyramidal. Okay, so just have a little idea about if this is the orbital cavity, how the eyeball is placed, how the muscles are inserted. Nothing more from this diagram as of now. We will keep getting into details in the later chapter. What is this? I mentioned axial length is seen by A scan. So you should know to recognize the slide of A scan. Yeah. So this is your A scan and this is the graph. This is how the peaks at different structures so that you can know the length from cornea till posteriorly, till sclera, to know the exact length. Just be familiar. This is how a B scan looks like for you. This is anteriorly, this is the lens, vitreous, this becomes your choroid, and this uppermost, this line is your retina. Okay? Yeah. So this is a B scan. You can say ultrasound B scan. It is used to see what? Structures behind the lens, that is, which is used to see the posterior segment of the eye. At the last, let us also discuss very quickly about the blood supply of your eye. The major part, the main artery the eye is supplied is ophthalmic. Please learn with me here only. So the eye is supplied by ophthalmic artery, which is a branch of internal carotid artery. Okay, at the last, we will also have a look at the blood supply of your eye. So let's learn together. The main supply is ophthalmic artery, which is a branch of internal carotid artery. Let's see next. So this should be very clear to you that carotid artery and ophthalmic is giving you three main branches: ciliary arteries, muscular arteries, and retinal artery. Okay, so the muscular artery which is supplying the extraocular muscles are actually the anterior ciliary arteries. They are called anterior ciliary arteries as well. Coming to posterior ciliary artery, which is also a branch of ophthalmic, posterior ciliary will be short or long. Common sense. If this is the posterior ciliary which is coming, short will supply what? The choroid and some part of the retina, right? And when you say long, long is going to come anteriorly at the base of the iris. Okay? And we'll talk about the details of anastomosis and all. So at present, just understand that posterior ciliary artery is supplying short and long. The short ones will supply your choroid and the optic nerve, and the long one will go to the iris and ciliary body. Okay, this much as of now. Let's see what I have the next slide. This is showing you the concept should be very, very clear here. This is the internal carotid. From there comes the ophthalmic. Ophthalmic is giving one branch as posterior ciliary artery. The short posterior ciliary will supply and the long will move further anteriorly here. Okay? Okay. And this branch, of course, is your retinal or central retinal artery. I want you to remember central retinal artery pierces the optic nerve and goes through the optic nerve and enters the eye. Okay? So just before entering the eye, it is already inside along with the optic nerve. Okay? And yes, what is circle of Zen? So part of the optic disc is supplied by anastomosis of these short posterior ciliary arteries, which were supplying the choroid and the retina part. Outermost layer, outer 4 layers of the retina and choroid. So the anastomosis between this short posterior ciliary arteries, and this is what is called circle of Haller and Zen, which is supplying the area of the optic disc. Okay? So you should know what is circle of Haller and Zen. So these are nothing but anastomosis of the short posterior ciliary artery, right? Okay. So of course, then the vein will come. What you have to know about the venous supply here. And also, if you can see from this diagram, the ophthalmic artery, these are the pial vasculature supplying the meninges and in the space. So you have to know this as well. But the most important is this. If you can know the flow chart, you can understand the blood supply. Come to the next one. What I want you to know from this slide and learn with me here, superior ophthalmic vein, inferior ophthalmic vein, finally draining into the cavernous sinus. But this is enough. No details needed. Okay. So mainly it is drained by superior ophthalmic, inferior ophthalmic into the cavernous sinus.